All right, Heather, I will go ahead and turn it over to you, and I will go ahead and spotlight your video so everyone can see you.
Hey, thank you, Lauren. Good morning. My name is Heather Peralta. I will be your presenter for today. A little about myself. Professionally, I have been supporting folks who have developmental disabilities for 23 years. I began my career supporting individuals living in group home settings, then moved on to DTA, which is the day training for adults. I have worked home and community-based services, providing respite care and habilitation for the individuals. The majority of my career, I have been a lead guidance trainer for the state of Arizona. I have worked for Gompers for 19 years as their staff trainer, working with, the staff to acquire new skills or just to sharpen up on existing skills that will assist them in supporting the individuals who have developmental disabilities. Now, those classes that I teach here at Gompers range from introduction to special needs, positive behavior support, CPR, first aid, transporting passengers with special needs. I also teach a class called Article 9, and what that is a prerequisite of the state of Arizona for anyone who will be providing services to an individual through the Division of Developmental Disabilities. That class there, it deals with managing inappropriate behaviors without violating the rights of the individuals that we support. For those of you here that have not heard of Gompers, we are a facility that's committed to serving adults who have developmental disabilities. We provide 2 DTA programs, and as mentioned earlier, that is day training for adults, where we teach habilitation, goals, life skills, social skills, independence, community involvement, etc. Gompers also offers job training and employment placement. So that's just a little about my background there. I do want to thank you all for being here and allowing me to join today to share some general information about transporting individuals who may need a little extra support. Now, the information that I am providing to you is based off of experience working with people who have unique abilities and research and training on the subject matter. I understand there is no one size fits all when it comes transporting passengers who may need a little extra assistance, but I hope the information that I provide today will help to assist in the safety of your passengers. So we'll go ahead and get started with the learning objectives. If we could go ahead to the next slide, please. So with the increasing focus on the safe transportation of passengers with special needs, today's drivers must be trained as professionals and schooled not only in defensive driving techniques, but also in safe passenger assistance procedures, keeping everyone's safety and dignity in mind at all times. Most of you here have probably gone through an in-depth training on how to utilize the van or the bus equipment and safe driving practices at your agency, but what we're going to focus on today is some information and tips on transporting passengers who have special needs. Now, this workshop today has actually been broken up into 2 sessions. So in today's session, we are going to describe general information and characteristics of the 4 developmental disabilities, including epilepsy, autism spectrum disorder, cerebral palsy, and intellectual disability. We will identify some of the types of visual impairments and techniques to assist passengers who are visually impaired. Next slide, please. Also in this training today, we're going to discuss communication with a person who has speech limitations, and we will cover some tips on communicating with a person who has a hearing impairment and techniques to assist passengers who have hearing loss. Next slide, please. Okay, so this training, like I said, it is designed for drivers who are responsible for the safe transportation of passengers who have special needs. Since you may transport folks who have a developmental disability, we want to start off by talking about just some general information about the disability itself. And then we'll discuss some tips on transporting passengers with special needs. So we're going to start off. The first developmental disability is epilepsy. We could go to the next slide, please. Okay, so the word epilepsy, it is derived from a Greek word, and that word is epilembanian, and that means to be seized or to be overcome. Epilepsy is a neurological condition that produces brief disturbances in the normal electrical functions of the brain. Normal brain function is made possible by millions of tiny electrical charges passing between nerve cells in the brain to all parts of the body. Next slide, please. Now, when someone has epilepsy, this normal pattern may be interrupted by intermediate bursts of electrical energy that are much more intense than usual. They may affect a person's consciousness, bodily movements, or sensations for a short time. Next slide, please. Now, epilepsy it's a broad term for brain disorder, okay, that causes seizures. I would say the difference between seizures and epilepsy, well, seizures are an individual occurrence of abnormal electronic energy in the brain, whereas epilepsy is a chronic neurologic disorder that causes repeated seizure activity. Now, depending on the type of seizure, they can last anywhere from a few seconds to several minutes. In rare cases, a seizure can last many hours. Now, a seizure that's lasting many hours is extremely dangerous, and that's because they do have a stronger chance of developing brain damage because they're just not getting enough oxygen to the brain. Now, there are many different types of seizures that we're going to discuss, but what most people don't know is that when a person is diagnosed with epilepsy, it's sort of common to them, but us seeing a seizure for the first time, well, it might be scary. I mean, the person may be convulsing, drooling may occur, they may lose control of their bowel or bladder. Now, because some seizures can lead to injury, or it could be a sign of an underlying medical condition, it is important to understand how to recognize a seizure so you can provide the best care. So on the next slide, we're going to discuss some of the most frequently identified causes of epilepsy. Now, as far as the causes of epilepsy, they do vary. Some people who have no clear cause of epilepsy, they may have a genetic cause, but in most cases, epilepsy is not inherited. Research does suggest that genetic abnormalities in a specific gene may be some of the most important factors that are contributing to epilepsy. But what is true for every age is that the cause is unknown for about half of the people who do have epilepsy. We know that epilepsy can strike anyone at any age. This is not something that someone can have immunity over. So let's start now with some of the most common causes of epilepsy. So the first one on the list there is trauma at birth, such as loss of oxygen or trauma during birth or just having a high fever. Now, sometimes a child will have a seizure during the course of an illness with a high fever. These seizures are called febrile seizures. They can be very alarming to parents and other caregivers. However, children with uncomplicated febrile seizures rarely go on to develop epilepsy. The febrile seizures, they usually occur in children aged 6 months to 5 years. You definitely want to seek immediate medical attention if this is the child's first seizure, or if there is no fever. You want to find out what the cause of that seizure is, so definitely get them evaluated by a medical professional. The second one on the list as far as causes is brain damage from illness or injury. Now, childhood diseases such as whooping cough, chickenpox, measles, it can lead to meningitis and it can damage the brain. Substances such as lead and mercury can also cause irreparable damage to the brain and nervous system. Vaccinating children at the recommended age may prevent some febrile seizures by protecting children against these diseases that lead to the high fever. You can also take precautions to prevent head injury. You know, there are safety measures such as wearing seatbelts in cars, putting children in car seats, wearing helmets, or, you know, when you're riding a bicycle or motorcycle, wearing protective headgear when playing competitive sports, just watching children around water, and other measures that prevent head injury and or other trauma that could cause epilepsy. The third one on the list there is excessively rough handling or shaking of infants, also known as shaken baby syndrome. So when there is a traumatic blow to the head or jarring or shaking of the brain, the impact of the brain against the rough edges on the inside of the skull can cause tearing of the brain tissues and blood vessels that may cause bleeding, bruising, swelling of the brain. Now, since the brain is covered by the skull, there is only a small amount of room for it to swell. This causes pressure inside the skull to increase, which can lead to epilepsy or other neurological conditions. Next one on the list, another known cause, is use of certain drugs or toxic substances when administered in large doses or are suddenly stopped. Now, I will be honest with you, as far as alcoholism, this part here is not my expertise, but what I do know is that it's not necessarily always the alcoholism in itself. In a lot of cases, it's just when they just quit, like they stop. You know, it messes with the brain and it can cause things like epilepsy. But of course, you know, seek medical professionals when it comes to questions and things like that, when it comes to that. But the other one, the next one on the list, interruptions of blood flow to the brain caused by stroke, tumor, certain cardiovascular problems. Now, in the history of time, there have been many misconceptions about epilepsy. Despite recent advantages, there are, you know, some cultures that still believe that epilepsy is contagious, but epilepsy is not contagious. You simply cannot contract it from another person by standing next to them, eating meals together, drinking from the same glass as someone who has epilepsy. It's not contagious. There are many different types of seizures, but we're in this session today, we're only going to discuss the two most common types of seizures. If we can go to the next slide, please. All right. So, I mean, honestly, sometimes it is hard to tell when a person is having a seizure. A person having a seizure may seem confused or look like they're staring at something that's not there. Other seizures can cause the person to fall, shake, and become unaware of what's going on around them. Seizures, they are classified into two groups. The first one is called a generalized onset seizure, and the second is a focal onset seizure. So the first one we're actually going to talk about here is the generalized seizure, okay? Now, this occurs when there is widespread seizure activity in the left and right hemispheres of the brain. The different types of generalized seizures are absent seizures, they're formerly known as the petit mal, and the tonic-clonic, or the convulsive seizures. These are formerly known as the grand mal seizure, okay? The grand mal seizure involves two phases. In the tonic phase, the individual loses consciousness and falls, and the body becomes very rigid, very tight. In the clonic phase, the muscles of the body contract and relax in rapid succession, causing the jerking and twitching. So that's the convulsions that we see. Next slide, please. So the generalized absent, like I said, used to be called the petit mal seizure, causes a brief period of 5 to 15-second lapse in consciousness, like blanking out or staring into space. Like other kinds of seizures, though, they are caused by brief abnormal electrical activity in the person's brain. During the absent seizure, the person is normally not aware of their surroundings and will not respond if someone is talking to them. The person's eyes may turn upwards, their eyelids might start to flutter. If they are in a conversation, I have seen people who are in the middle of their conversation, like in the middle of the sentence, and then they just kind of go back into that sentence, and it just may sound like a mere pause to others. Absent seizures, they usually affect only a person's awareness of what's going on at that time with immediate recovery. Now, these types of seizures, they're pretty quick, so quick that you may even miss it. And if you miss a seizure, there's not really a whole lot you can do. If you happen to see the seizure and you know that they have the petit mal seizures, then yeah, we'll get into documentation and all that good stuff. Now, when the absent seizure ends, the person usually just, continues doing whatever they were doing before the seizure. They're almost always wide awake and able to think clearly. Like I said, generally, there's really not a whole lot of first aid that you're going to need. Just monitor if you see it. Okay. Next slide, please. The next type of seizure that we're going to talk about are the focal onset seizures. Unlike the generalized seizures that show activity in the left and right hemispheres of the brain, the focal onset seizure affect just one area of the brain. These seizures are also called partial seizures. They begin in a specific location in the brain. Now, partial seizures may cause cognitive impairment, difficulty thinking or remembering, or interfere with the body's sense on only one side or part of the body, or it may affect the entire body. Now, there's two main types of focal onset seizures. It's going to be the focal onset impaired awareness seizure and a focal onset aware seizure. So we're going to actually explore the differences here. So it says the focal onset impaired awareness seizure is when a person is confused or their awareness is affected in some way during a focal seizure. This used to be called the complex partial seizure. And then you also have the focal onset aware seizure. And this is when the person is awake and aware during the seizure. These ones used to be called the simple partial seizure. Next slide, please. Okay, so the focal onset impaired awareness seizure are the most common type of epilepsy in adults. These seizures, they can last between 30 seconds and 2 minutes. People having this type of seizure may appear to be daydreaming or just staring off blankly. Next slide, please. So as far as signs to look out for, they could include, the person not being able to respond for a few minutes. They may start swallowing or smacking their lips, picking at things like the air, clothing, or furniture. Say words, just repeating different things. They may appear to be dazed or confused. The person may scream, laugh, start crying. It can also include random walking, which I actually want to talk about for a minute. It is important to note that the person may walk around during the seizure, but not be in control of where they're going. And that could actually put them in danger, especially if they're walking towards something, dangerous. First thing I want to say though is if the person does start walking around, you do not want to restrain them. Okay. However, you do want to protect him or her by maybe just moving things out of the way. If they're walking towards something on the floor, if you can move it out of the way, great. If not, if it's like a table or something that they're walking toward, my recommendation is always just kind of walk in front of them and then just kind of stand there. What'll happen is generally they'll just kind of go off the other way. So just follow them, making sure that they're safe if wandering does occur. Okay. And the reason I say don't restrain them, don't put your hands on them is because I've seen it personally where a person does try to relocate them by putting their hands on them. I've seen people get hit. They start swinging and the person may not even realize that they're doing it. So it's just always caution to use your body just to kind of prevent them from going into a dangerous space. All right, next slide, please. All right, so that was the focal onset impaired awareness seizure. So now what we're going to talk about is the focal onset aware seizure. This is when a person is awake and aware during the seizure. This seizure, it starts in one area of the brain and then the person, remains alert and able to interact. These seizures are pretty brief, lasting seconds to less than 2 minutes. The person may experience a change in sensation, like a strange taste or smell. Twitching may occur. Say the best thing that you can do for this person is to monitor the seizure, keep them comfortable, and just stay calm. Okay. When the focal aware seizure ends, the person usually just continues doing what they were doing before, it started. This type of seizure, though, it can actually be a warning or an aura before a stronger seizure occurs. And a lot of times that's when it's a little bit more serious to where they could lose consciousness. But that could just be like a precursor to another seizure. Okay. Now, as far as how to recognize a seizure, let's go ahead and discuss some of that information and what you can do to support the person that is having a seizure. We could go to the next slide, please. Okay, so first aid, we're just going to talk, best practices. If someone is having, I'm going to start off with the tonic-clonic. This type of seizure, grand mal tonic-clonic, is often the most dramatic and frightening, but it is important to realize that the person undergoing an epileptic seizure is usually unconscious. The seizure usually lasts a few minutes and the person doesn't need medical care. If you see someone having a seizure, there are some simple things that you can do to help. And the very first thing that I have on the list there is to stay calm. Don't try to revive them. All right. You want to let the seizure run its course because, one thing, if you start to panic, so will everyone else in the vehicle, and you're not going to be able to provide the best care. So staying calm is always top priority. The second one on the list there is to protect the person from injury by helping them to the floor if needed. Now, the reason the person generally gets hurt during a seizure is if they fall. This is also known as like a drop seizure. If the person is sitting in the vehicle and starts to lean sideways toward the aisle, you can just kind of stand there and let them lean up against your body just to prevent them from falling all the way to the floor. Now, if the person is in a wheelchair, just put the brakes on, leave any seatbelt or harness on unless it's causing injury, and just monitor the seizure. There's no reason to have to take them out of their wheelchair. There's no reason to move them. Now, let's say you're in the vehicle and they're on like the outer seat and they're starting to go forward. Now, if they're already pretty much going toward the floor and you are just pulling the van over to safety, if you're there, you can kind of help them down, to the aisle where there's room, just trying to make sure they don't hit their head. Now, of course, if a person does fall, we never want to just pick them up. Okay. So if this individual, even after the seizure, is not able to stand up on their own, it's just take caution, just call 911, because if they did fall, they could have broken a hip, they could have hit their head, their spinal cord could have went out of alignment. So just, use caution when it comes to that kind of thing. Don't move them. And then actually moves into the next one. Only move a person if they're in danger. If they have a seizure as they're walking to the van and they're now on the floor on the hot concrete, they're going to burn, you know what I mean? So, or if there's traffic coming, if they are crossing the street and they fall due to the seizure, I mean, there might be some situations where you may have to move them, but of course, I mean, I'm not sure as far as the extent of training, but like even in like CPR classes, we teach how to move someone safely just in case, injury did occur. Okay. The next one on the list there is, oh yes, to time the seizure. It is important to time the seizure. You want to look at your watch at the start of the seizure to time its length, or if you didn't see it start, just kind of estimate the time. In general, if the seizure lasts more than 5 minutes, we'll call for an ambulance. I say in general because some folks who have epilepsy, they may have a specific protocol for their seizures. If the person has a seizure action plan, it will tell you what to do for that person if they have a seizure, which could include, giving them their rescue medication, if they have seizure clusters, or using their vagus nerve stimulator, which I'll talk about what that is in a minute, or just any specifics on when to seek medical help, but I'll say if the protocol says monitor, that's all you're going to do. You're going to watch, you're going to time, make sure there's no safety issues. And then again, if the seizure goes 5 minutes, then call 911. But again, read the protocol because it may say call 911 after 2 minutes. read the protocol so you know best practice for that person. If we could look on the next slide, please. Thank you. All right, let's see. Oh, next one on the list, check for a medical ID. Yeah, some people who have epilepsy, they do wear like a special bracelet, pin, necklace, or they may carry a card to let medical professionals know if someone is, oh, thank you. Lisa, bless you. To let medical professionals know if this person does have epilepsy. I actually have a friend of mine who on his wrist, he has a tattoo of his medical condition. He also, and I'm smiling because I've seen the tattoo, he has an allergy. This man is allergic to bees. So his tattoo next to his diagnosis there, his diabetes, he has a bee, okay? It's a cute little bee. And there's a little quote there next to the bee that says, "I am cute, but the person with this tattoo is allergic to me." I'm like, that's creative. It's comical. It's telling medical professionals, hey, if I've been stung by a bee, I need to, go get my EpiPen or get me to the hospital, So I think that's kind of a creative way too, if you're comfortable with something like that. But when it comes to medical IDs, I just always say, if you're at Walmart and somebody's convulsing on the floor, look for a medical ID. Okay. And if it says that they have epilepsy, we'll just start timing it. It's not a medical emergency. But I always say too, if they do not have a medical ID and they are convulsing, I am calling 911 immediately because I have no idea why this person is convulsing. I mean, this could be a diabetic seizure, which is a medical emergency. So just always look for that medical ID. The thing is, though, if you're transporting, someone that you've been transporting for a while, it's very possible that you're going to have some information on them and know if they have epilepsy. Okay, so always read those sheets. All right, the next one, what's the next one? Loosen any tight clothing? Yeah, okay, so loosen any tight clothing around their neck, such as a collar, tie, to aid in their breathing. I always say too, if they're wearing glasses, remove the eyeglasses. You may also need to remove dentures, only if they're loose. And I always want to say a recommendation on how to do that. If you clearly see that they're loose in the mouth, with gloved hands, I would go in with the thumb, and I don't know if you can see this or not, the thumb and the middle finger, and just go in from the side here and pull them out instead of going in full front, because if they clamp down on that, their jaw may lock, and then, you don't want to lose digits. So always go in from the side when it comes to removing dentures, only if they're loose. The next one, do not put anything in the person's mouth. Now, in the past, people would stick something like a wooden spoon or a wallet in the person's mouth during a seizure. The reason they were doing that was, well, to prevent them from swallowing their tongue. It is physically impossible to swallow one's tongue. If we could, we would do it every night when we're sleeping. Now, of course, the tongue is going to rest on the back of the mouth there, but it can't be swallowed. Putting things in the mouth may lead to injury, okay? And it has. If the person was to bite down, let's say on that solid object, could chip their teeth, cut their gums, and even break their jaw, okay? Now, if the person is having a seizure and they're like biting their tongue, you can roll them over onto the other side and the tongue will just kind of fall to the other side of the mouth, okay? Let's see, the next one, do not hold a person's body or head. Okay, yeah, definitely not. You should never attempt to restrain or hold a person having a seizure. This increases the chance of them suffering an injury. Could be a broken bone, dislocated shoulder, In addition, it does put you at risk from sustaining injury as well. If the person, let's say, is hitting their head on the ground or even on the vehicle window, put something soft there, okay? Maybe a blanket if you have one on the vehicle, a jacket, some kind of a cushion maybe you keep on the van just in case, because if this person has a known condition, of epilepsy, just have something there just in case. The bottom line is we never want to hold them down, because if they're, I'm going to go like this, like they're hitting their head on the window, their neck muscles are needing to do that. And if we keep them still, we could actually, worst case scenario, I mean, we could paralyze the person. So again, if they're hitting their head on the floor, just put something soft. Have I used my hand until I got something soft? Yeah. Had a young lady that I was supporting. We were at where were we? It was a Special Olympics baseball, or no, it was basketball game. And she was on the bleacher and I was sitting right next to her, and she, started to fall forward, going into a seizure, and I kind of helped her down. But I just used my leg. She was hitting her head on my leg. I had a nice little bruise there on my thigh, but her head was safe, so just never hold them down. That's the point. Okay. All right, next slide, please. Yeah, do not offer the person water or food until he or she is fully alert, just because it could cause them to choke. If they do have food or fluid in their mouth, roll them to the side immediately, again, just to prevent choking. Avoid talking loud and touching the individual during the seizure. Now, in some cases, when a person is having a seizure, their senses, they may be heightened. Sound may seem louder, kind of like amplified in the brain. And also they might be sensitive to touch. So even just kind of rubbing their arm here, or doing this to their face, they could have those, sensitivities to it. Not in all cases, but in some cases, people have explained, what it's kind of like when someone is just being loud or touching them. So a lot of times they just prefer not to be touched. All right, the next one is to assist the person in preserving their dignity should the seizure occur in public. Yes, people tend to gather when they see an emergency. Now, if this occurs, just let bystanders know that it's under control. Okay, we appreciate your concern. And that's usually what I say. I would never accuse anybody of just being nosy. I would never. But the thing is, thank you for your concern, but we do have this under control. I just think that is the nicest way to handle that when you have a lot of people gathering around this individual. You just don't want the person to come out of the seizure with a bunch of people standing over them. More than likely, this person's going to be confused. Embarrassment could set in, especially if they've eliminated on themselves. If you need assistance, it's totally fine to, ask somebody to stay with you. Maybe you need someone just to time the seizure. Maybe if there is, injury that's occurring, maybe you do need some assistance. Maybe you need someone to call 911. You know what I mean? But we just don't want a lot of involvement. That's it. All right, next slide, please. Okay. After the seizure, the person should be allowed to rest or sleep if necessary. Now, I've never had an epileptic seizure, but I have spoken to many, many people who have, and they say it's exhausting. That's what a lot of people say. It just takes a lot of energy away from them. So if the individual, is in the van and they fall asleep after the seizure, I mean, that's pretty common. After resting, most people, they just carry on as before. So when to call 911? Okay, I think that's a great question. All right. Call 911 if this is the person's first seizure, if the seizure lasts more than 5 minutes, if the person does not regain full consciousness, if they have several seizures without regaining consciousness, these are also known as reoccurrent or cluster seizures, or if the person is seriously injured during the seizure. Those are some times to call 911. But I'm just going to say it again, just read their protocol, because like I said, it could give you more specifics about that person's seizure. Okay. Next up, we are going to discuss some of the common triggers to seizures. So if we could go to the next slide, please. Okay, so the first one on the list there is sleep deprivation. Okay, just being overtired, not sleeping well, not getting enough sleep. Disrupted sleep can also influence a seizure for someone who has epilepsy. The next one is flashing lights or patterns. One of the individuals that I used to transport, she would have a seizure if she looked directly at like a police vehicle or any emergency vehicle that had their lights activated. Okay. She knew her trigger. So I swear she could hear the sirens way before I could. Okay. And I'm like, seriously, where's it at? And she's like, I don't know where it's at, but I can hear it. So what she would do is she would just kind of put her head down and just kind of block her eyes. And she would ask, let me know when it's, completely gone. And that's something that she would do, just try to prevent, having a seizure, because again, she knew what her trigger was. Another trigger can just be not eating well. Long times without eating, dehydration, just not getting enough fluids. Low blood sugar, vitamin and mineral deficiencies can trigger seizures in some cases. Specific foods, excessive caffeine, or other products that may aggravate seizures. If the person misses their medication, so yeah, missed doses of seizure medication, it's actually one of the most common causes or triggers. Missed medications can trigger seizures in both people who have well-controlled seizures, and if they're poorly controlled. Just missing medication, though, could be a trigger. Let's see. The next one says stress or excitement. Heat. Oh, that's another big one. We know summer. We're getting away from summer, but we know summer. It can bring extreme temperatures. Some people with epilepsy, they may be very sensitive to the heat. We tend to see a lot more seizure activity in the summer. Can't get around it. It's inevitable. But as drivers, there are things that we can do to try and reduce seizure activity. Okay. One of the things, well, actually, we've got a couple individuals here at Gompers that the driver has an umbrella waiting for them. So when they go and pick them up, the individual holds the umbrella just to kind of shade them a little bit. Other things that we do here is we try to make sure people remain hydrated throughout the day. Even wetting their face before they go outside, wetting their hair, just so it's kind of cools them off just a little bit, maybe a wet towel or something around their neck. Like I said, we do what we can, but I don't know, it's the heat. It's a huge trigger, and we see a lot more in the summer. All right, if we could go ahead and look over onto the next slide, please. Okay, so earlier I did mention the vagus nerve stimulator. What that is a battery-powered device that is surgically implanted under the skin of the chest. It's kind of like a pacemaker, kind of right underneath the skin there, and it's attached to the vagus nerve in the lower neck. This device delivers short bursts of electrical energy to the brain via the vagus nerve. On average, the stimulation reduces seizures by 20 to 40%. It may also reduce the time it takes to recover after a seizure. It's unlikely to completely stop the seizure. I mean, it's a very low chance, but again, it does help with recovery. And another thing too, the vagus nerve stimulator, it doesn't cure epilepsy. Okay. Now, the vagus nerve stimulator is used for people with typically with drug-resistant epilepsy. This just means that seizures are not controlled after trying at least 2 appropriate seizure medications. It's just kind of like an add-on, which means they're going to use it in addition to seizure medications. That's in most cases. Now, if the person has a vagus nerve stimulator, okay, it will be documented on their sheet that they have one, or, if you have that opportunity to speak to someone that maybe is dropping them or walking them to the van, or if it's, picking up someone from a DTA, they may give you that information. But anyway, the vagus nerve stimulator, the individual's going to carry a magnet. It's about this big. It's usually a black magnet. Sometimes members may wear it as a bracelet. They may keep it on their belt. Some of the individuals may keep it in their backpack. Okay. Like in DTA settings, like the staff that work with the individuals, they know exactly where it's at. So it's good to communicate that kind of stuff. But if there is an indication of a seizure, or if the individual is already having that seizure, what you want to do is you want to take that magnet and you want to swipe it going from the left chest up to the left armpit. Like, you guys can't really see me here, but like going straight up. well, like diagonal from the left part of the chest up to the left armpit, and you wait 60 seconds. If the seizure is still occurring, you may swipe it again. Now, as far as the clothing, like my shirt here it's fairly thin. You don't have to remove the clothing if it's a shirt like this. However, if they're wearing like a big thick jacket, something like that, then absolutely pull it back and then go ahead and swipe one time every 60 seconds. Okay. Now, again, that's unless the person has a specific protocol. If it says swipe one time and if they don't come out of the seizure, there's going to be separate protocol, because sometimes you just do it the one time. It just depends on the individual, but that's the basis on how to use it. Little black magnet, you just swipe it one time across the vagus nerve, and it sends that stimulation up to the neck through the vagus nerve up to the brain, which again is just to assist. Okay, now of course, if the seizure doesn't stop, follow protocol. After 5 minutes, call 911. All right, let's look over. Oh, where's my paper? Let's look over on the next page here. Okay. So the agency that you work for may require you to complete a seizure report form if someone on your transport vehicle does have a seizure. I do have the example there on the slide. This is actually the seizure report form that we use here at my agency at Gompers. So I'm just going to briefly go through this just to give you an idea of what it might look like or what to look out for during the seizure. Okay. So, I mean, if you can see there, we've got the basic information, you know, the member's name, their date of birth, all that information is going to be, you know, on their fact sheet if that's something that you have access to. But even if it's just a basic seizure report form, where it says pre-seizure activity, just put in what they were doing right before. Were they their usual self? Were they resting? Were they lethargic, quiet, sleeping, agitated, excited, sitting, walking, swimming, eating, exercising, unknown? Now, most cases, I mean, if the person has a seizure on the van, they were just sitting in the van. You know what I mean? You're just going to put what were they doing just prior to the seizure. Okay. And you can even make side comments. Like if it's really hot in the van, you can make a little comment like that. If the individual falls asleep while you're transporting them, you can always put that in there as well. Just anything going on pre. And then symptoms during seizure. This is good just to kind of keep so you know what to look out for when they're having that seizure. So the first one, we're going to look at the face. Was it unchanged? Were they sweating? Were they pale, rigid, turning blue, flushed, unobserved? Let's see, their mouth, was it unchanged? Were they biting their tongue, chewing, teeth grinding, drooling, foaming, drooping, lips tightening? Okay, eyes unchanged. Were they pulling from side to side? Was the eyebrow twitching? Were they rolled back? Were they just staring? Were the pupils dilated? You know, or it says unobserved, but maybe they were closed. You know, just put in a little side note that the eyes were closed. You're going to check their breathing. Was it unchanged? Were they breathing very fast, very slow? If their breathing is interrupted, go ahead and put by like how many minutes did they kind of hold their breath. Body, check their body. Were they convulsive? Was it their entire body? Was it just one arm, one leg? Were they tight? Were they limp? Movements, were they aimless, wandering, picking at clothing? And then incontinent, did they urinate on themselves? Did they have a bowel movement? We have unobserved here, but like none of the above. Okay. It could be vomiting, any type of elimination. Okay. So this is just kind of a baseline on what we use. I mean, your own agencies may have their own, you know, type of form if they do require that. Okay. Real quick, I do want to talk about what do, you know, if you're driving and the person has a seizure? Well, of course, pull the van over in a safe position as soon as you recognize the seizure. Now, most cases, if you have multiple passengers on the vehicle with you, more than likely someone's going to say, driver, Jenny's having a seizure, or, you know, something's wrong with Jenny, you know, then you just pull over. The rear view mirror in most of the vans, you really can't see out the back window. So you can kind of have it facing the individuals. The two side mirrors, that's really to see what's going on outside the vehicle. So you can have it kind of faced on them just so you can kind of see what's going on. Okay. All right, let's see here. Next slide, please. I think it's what, communicating? Oh, that's the back of it. Well, the back of it, we just fill in some information, what happened after we make all the phone calls. This is our protocol here. I didn't know you guys had the back. All right. Yeah, we can go ahead and move on. Yeah, communicating. That's what I thought. Okay. Um, communicating seizure activity. All right. It is important that we keep each other informed regarding the individuals that we transport. This is especially true for individuals with epilepsy because seizure activity can affect a person's mood, concentration, and ability to participate in some activities. Let's go ahead and look on the next slide, please. All right, after the seizure. Yeah, I want to talk about that. The person may remain unconscious for several minutes as the brain recovers from the seizure activity. The person, like I said earlier, they may appear to be sleeping. They could be sleeping. You may hear snoring. Generally, the person regains awareness and may feel confused, exhausted, physically sore, sad, even embarrassed for a few hours. The person may not remember having the seizure and may have memory loss. It's okay to explain to them that they did have a seizure. Occasionally, people may have abnormal or combative behavior, usually after a tonic-clonic seizure, like I said, while the brain is recovering. Now, I kind of went over this just a little bit earlier, kind of jumped a little bit, but seriously, some of you in this training, you've been transporting the same person for a while now, and you have had the opportunity to gain some information about them. However, if you are going to be picking up, a different passenger every day, hopefully, if the person has someone there with them on the pickup spot or the drop-off spot, they'll give you some basic information about the person, but if not, I hope the information that we discussed on epilepsy, it does help to understand how to recognize a seizure and then just what can we do to help. But if you would like additional information about epilepsy, we have the CDC's website there. They have a lot of great information on epilepsy as well. Main thing, we've got to get to know the individual and what type of seizures they have so we can better support them during that seizure. All right, if we could go to the next slide, please. All right, so the next developmental disability that we are going to discuss is autism. Before we do though, and before we go to the next slide, I kind of want to open this up a little bit, if you don't mind. If we can open up the chat. When you think of autism, what comes to mind? What do you think about when you hear autism? I kind of want to see where you guys are. And Lauren, if you don't mind reading what they say.
Of course.
Appreciate it.
I'm not seeing any in the chat yet.
That's okay.
But I can go ahead and answer if that's allowed.
I would love it.
So when I think of like autism spectrum disorder, I remember having several classmates in elementary school who were autistic, and some were verbal, some were nonverbal. But I remember the ones who were verbal having difficulty sometimes putting sentences together, like remembering what words they wanted to use. And then I have a cousin who has Asperger's, so kind of those social cues and things. So that's what I think of.
Yeah. All right. Well, I appreciate that feedback. Yeah. Okay, great. I appreciate that. Let's go ahead and look over onto the next slide and let's talk about it. Let's talk about autism. All right, so says there, autism impacts the normal development of the brain in the areas of social interaction and verbal and nonverbal communication skills. Autism spectrum disorder affects how a person acts, experiences the world, and expresses themselves. Now, because autism is a spectrum disorder, each person who has autism, they are going to have distinct set of strengths and challenges. The ways in which people with autism learn, think, problem solve can range from highly skilled to requiring much assistance. Some people who have ASD may require significant support in their daily lives, while others may need less support, and in some cases can live independently. Now, a diagnosis of ASD, it now includes three main conditions. So if we could flip to the next slide, please. Okay, so the first one is ASD level 1. This is formally known as Asperger's syndrome. This is the mildest form of autism. For example, for some folks who have level 1, okay, they have a great attention to detail. They can be highly articulate in writing and speech. They may also have interest or expertise in specific areas like math, computers, music, cars. I have a friend of mine who her 6-year-old son is diagnosed with level 1, and whoo, this little boy, he is obsessed with the brain. Okay, when I say obsessed, he's got books and apps, and one of the toys in his room is that skeleton guy that you see in the doctor's office or something. And he's just obsessed with like anatomy and things like that, but his main focus is the brain. It is. And he doesn't do well playing with other children. He's usually at home. He likes to spend time, just with himself. But I told his mom, I just told her, I said, you know what you produced? And she goes, what do you mean? What did I produce? What do you mean? I go, you know what you made? And she goes, what? Heather, what? I said, right there, that little boy. Okay. That's brain surgeon. I'm almost 100% positive that when he grows up, I have a feeling he's going to do something there, because people who have level 1, they don't typically work at McDonald's or anywhere where there's a lot of people. People who have level 1, they are computer engineers. They are, because they take apart the computer, they put it back together, they focus on it. You could ask the 6-year-old little boy, what part of the brain, what lobe is the memory? And he'll point right to it. He's like, this is it. And then he'll explain it. He's 6. So the thing is, a lot of times they have that expertise at a very young age. Now they may also have logical approach to problem solving. Okay, the list goes on. Now, those on this level, okay, yes, we know they may require some support when it comes with issues like inhibited, I can't say the word. My brain is not there. Social interaction, okay? Lack of organization skills, planning skills. They may struggle, with those types of things. Let's now go to level 2. Let me get my voice back. All right, remember how to say some words. Level 2, currently, this is classified as mid-range, okay? Individuals who are diagnosed with level 2 ASD, they do require substantial support. They have limitations that are more readily obvious to others. They may have trouble with verbal communication, have restricted interest, and exhibit frequent repetitive behaviors. But to add, some individuals with level 2 autism, they have exceptional memory skills, particularly recalling factual information or details about areas of interest. Level 3, currently classified as the most severe end of the spectrum. Individuals at this level, they require very substantial support. Signs of level 1 and 2 are still present, but are far more severe, and they're accompanied by other complications as well. Individuals at this level, they will have limited ability to communicate and interact socially with others. But on the other hand, they can focus intently on specific interests, which can lead to, great skills and expertise. I say with the right kind of help and understanding, people with level 3 autism, man, they can do incredible things. They just need that support to kind of guide them along the way. If we could look over on the next slide, please, we're going to talk about some of the characteristics of autism. Now, diagnosing autism spectrum disorder, it can be difficult because there's really no medical test, like a blood test, to diagnose the disorder. There is no known single cause for autism spectrum disorder, but it is generally accepted that it is caused by abnormalities in the brain structure or function. Brain scans show differences in the shape and structure of the brain in children with autism compared to the brain in neurotypical children. Doctors, they look at the child's development history and behavior to determine a diagnosis. There are many different characteristics that doctors look for when they are diagnosing a child with autism. The individual must demonstrate impairment in each of the three primary characteristics that are right there on the slide for you. The first one is social interaction, communication skills, and repetitive or restricted behaviors. And that could just be like ritualistic behaviors such as rocking back and forth. And we'll go more into those types of things like sensory sensitivities. You know, we're going to discuss more in detail on that here in just a little bit. For now, though, if we could go to the next slide. Okay, so here are just some MRI scans that revealed that kids with autism have deficits in a brain pathway that normally makes social interaction feel rewarding. Nerve fiber tracks along the pathway in red there are less dense in children with autism than in the I'd say typical, because like, what's that mean, right? What's typical? Typically developing children. So it's kind of got the differences there for you. If we could look on the next slide, please. Okay, so what we have here is a list of some of the characteristics that doctors look at when they're diagnosing a baby or a child with autism spectrum disorder. So these early indicators: no babbling or pointing by age 1, no single words by age 16 months or 2-word phrases by age 2, no response to their name. They may have poor eye contact and lack facial expressions, excessive lining up in toys or objects. We see that a lot in children who have autism. There may not be any smiling or social responses at a young age. Next slide, please. A person who has autism, they may also resist physical contact and may seem to prefer being alone. They may not speak or has delayed speech, or the person may lose the previous ability to say words or sentences. So if you are transporting someone who is non-speaking, you may be able to recognize the different sounds that they make, and it'll give you that indication, like happy, excited versus angry and done. It's like you can kind of hear that pitch in the sounds that they're making to determine, you know, how they may be feeling. A person who has autism, they may also speak with an abnormal tone or rhythm. They may use like a sing-song voice or a robot-like speech, or repeat words or phrases from things that, you know, they've heard, like someone said something, repeating different things. Now, that type of communication is called echolalia, and I'm pretty sure in this, I think in this session today, if I remember correctly, I elaborate a little bit more later on echolalia. Okay. Let's see, what's the next one? What is the next one? They may not appear to understand simple questions or directions. They may have difficulty recognizing nonverbal cues, such as interpreting what other people's facial expressions, body language, or tone of voice, and appears unaware of others' feelings. Now, people who have ASD, they may talk constantly about specific things that interest them, but be very unaware that other people may not have that same level of interest about the topic. They may not have that sense of, okay, stop, because this person doesn't want to talk about this anymore. They may not be able to get those social cues. People who have ASD usually have difficulty with social interaction. Some parents, they said that before their child was diagnosed with ASD, they just thought that, you know, their child was very shy, you know, and then they get the diagnosis and they're like, oh, well, that makes sense why she's always playing by herself and not with the other group of kids. Now, I do say that, but just because there's a child that is playing by themselves, that does not necessarily mean that they have autism. It could be just that that child does prefer to be by themselves. Of course, you always want to get the child evaluated if there is any question, of course. All right, next slide, please. I think we're going to continue on with the characteristics. Individuals who have autism also commonly experience sensory issues to one or more of the five senses. And the five senses are sight, touch, taste, smell, and hearing. For example, some people who have ASD may react to bright sunlight. Others are excessively bothered by even like tags on their clothing or by loud noises. Many people may be bothered by these things, but people who have ASD, they may have a stronger reaction to them. Okay. Another characteristic of autism is they may display repetitive behavior or repeating words or phrases. They may do the repeated body movements. Okay. People who have ASD, they sometimes they do the same things over and over. For example, the repeated hand flapping where they're, flapping their hands or rocking back and forth or jumping up and down, spinning, like just turning in circles. Sometimes they may walk on their tiptoes. All right. So this here, that is known as stimming. Okay. And I want to talk about what that is here for a minute, because to be honest, everyone stims. It's a universal behavior. Like I said, it occurs in anyone. You guys, I can't see you right now, but you might be stemming right now. So let me grab something here. If you are just holding a pen and you're doing this is stemming. Or if you're sitting and you're rocking your leg, or if you're twirling your hair, everyone stims. All right. It's not something that's exclusive to autism. Okay. Now, some people may stim, some people may not. Now, for people who have autism, if they have like oversensitivities to sensory information, stimming can help to reduce the sensory overload because it focuses their attention on just that one thing, or they may be doing these things to help calm themselves down during stressful situations, or they just do it to kind of entertain themselves or occupy themselves. Everyone stims, like I said. Now, as far as the hand flapping, okay, we see a lot of members or individuals who have autism that flap their hands. I always say, the next time you see someone who has autism that is flapping their hand, look at their eyes. 9 chances out of 10, they are looking at their hand and they're like focused on it, because that is a way that can help them kind of, what's the word I'm looking for? Like drown out everything around them by just focusing on that one thing. And it really helps. Like I said, if they're becoming overstimulated, loud room, a lot of people in the room, the lighting could be, upsetting them. There's so many different triggers to certain things, which I believe I talk about in the de-escalation workshop. I think we just had one a few months back, and I talk a lot on that. All right. Let's see. What's the next one on the list? Difficulty in routine. Yes. Okay. Many people who have ASD, they seem to thrive so much on routine that, changes to the daily pattern of life or an unexpected stop on the way home, it can be very challenging. Some people may even get angry or have emotional outbursts, especially when they're placed in a new, overstimulating environment. Okay. Later on in the course, though, we will discuss some tips to make this change a little more calming for the individual. That's actually something that we will discuss in the second session. Okay. Person with autism, they may also have strong attachments to objects. Now, in this case, aggressive and or self-interest behavior may be present. All right. The person may become obsessed. Okay. So when it comes to autism and OCD, those kind of go hand in hand with each other in most cases. Now, it may not be that they're trying to hurt you, but they will do whatever it takes to get to what they want, even if that means going through you, which I've seen that. Actually, I work with an individual that when their mind gets set on something, and if he feels that he's being challenged, yeah, he may scratch or tug at our clothing to get what he wants. One of the things that we've noticed that he's obsessed with is the knob on the radio, okay? Because, you know, the turning and the spinning, he's obsessed with it. Now, like I said, if they've got that unusual interest in objects, this could become a challenge, especially when he's trying to work the radio and you're trying to drive the van. So what we've done for this person is we tried to come up with some different ideas to kind of stimulate his brain while the van is moving. So what we did was we got him a little toy car. Okay, you know, the toy cars, they have wheels. So we have him hold on to that so he can just kind of spin the wheels while we're driving the van. That worked for a few months. Then we had to come up with some, you know, different ideas because he was getting bored with the little car. Sometimes the driver would bring a different color car. We've also noticed that he likes the fidgets, the little fidget spinners. So while the van is in motion, he can sit there and he can fidget with it. When the van pulls over, this is something that we're working with him on. When the van pulls over, you know, maybe to let someone off the van, the driver will allow him to just flip the radio a couple times just to kind of get that. And then, you know, teaching him to go back, put his seatbelt back on. And, you know, it's just something that we're trying, you know, to assist him, you know. All right. Let's see the next one. Let's see. What is the next one? Oh, strong attack. I just remember that. If we could go to the next slide, please. Okay. So I guess I want to speak a little bit more. As far as autism, let me just kind of finish that up. When it comes to someone who has autism, they may have difficulty with things like, I don't know, holding a pencil. Okay. But they may have a strong memory for words or songs or movies. A person may have difficulty knowing how to play a game with a peer, but maybe have exceptionally good understanding of how computers work. You know, they may not be able to speak, but they may be able to make complex structures with Legos. Okay. This is why autism is a spectrum. There is a wide range of behaviors and experiences that are considered to fall under that umbrella of the autism diagnosis. Okay. The autism is going to look different for everyone. Okay. It's a spectrum. So I want to end it here with autism. If you've met one person who has autism, you have only met one person who has autism. Okay. A lot of times I've heard people say, you know, my great aunt Sally, you know, she has autism. I know everything there is to know because, no. Aunt Sally is going to be unique compared to Bill or Joe or Sam who has autism. So we want to get to know a little bit of information about the diagnosis itself, sure. And that's what we just did, a little introduction, okay? But get to know the individual on the vehicle. Get to know their preferences, get to know their sensories, get to know their routine. Okay. All right. I'm going to get off that right now. Now we'll go ahead and we'll move on. We're going to talk about cerebral palsy. So if we could go on to the next slide, please. All right. So definition of cerebral palsy. Cerebral palsy is a condition resulting from damage to the areas of the brain that control movement. It's not a disease. It's a group of disorders that affects a person's ability to move and maintain balance and posture. Cerebral refers to the brain. Palsy refers to lack of muscle control. Cerebral palsy is a group of disorders whose major feature is brain damage. Now, the abnormal development of the brain or damage that leads to CP can happen before birth, during birth, within the first, few months of life, while the brain is still developing. Once the disorder appears, though, usually in the first few years of life, it doesn't worsen. Cerebral palsy, it can range from mild to severe and is purely a physical impairment. However, in more than half of the cases, people who have CP, they also have cognitive disabilities. In addition, many people who have CP, they also have seizure disorders. Next slide, please. I'm going to talk risk factors. Now, many of the signs of cerebral palsy may be present at birth or may not be seen for months or years later. A diagnosis of cerebral palsy may occur immediately after birth, but more commonly occurs between 15 and 24 months. Next slide, please. Should be okay. So we're going to talk a little bit on the causes. There is no single cause of cerebral palsy. For most babies born with CP, the cause remains unknown. But we are going to discuss some of the things that may increase the chance that a child will have CP. Now, these are called risk factors. It is important to remember that having a risk factor does not mean that the child will have cerebral palsy, okay? But there is a chance that this could happen. So some of the risk factors, the first one is asphyxia. This is just lack of oxygen to the brain, trauma to the head during labor or delivery, and I'll put some business out there. My uncle, okay, he is 71, I believe. He has cerebral palsy, you know, from way back then. They were this is my stories my mom have told me, but they were getting, you know, him out and they were using the clamps and they clamped his head and it caused that injury. So now he has CP on the left side of his body. Okay, so that was just trauma, head injury during that delivery. Abdominal injury during pregnancy, absence or lack of prenatal care, infections during pregnancy, such as rubella, birth complications such as anoxia due to problems with the umbilical cord during birth, that can definitely disrupt oxygen supply to the baby, which can result in CP. The next one is low birth weight. Yeah, children who weigh less than 5.5 pounds at birth, and especially those who weigh less than 3 pounds, 5 ounces, they do have a greater chance of having CP. Again, not a guarantee, just there's a higher risk. Premature birth, so children who are born before the 37th week of pregnancy, especially if they're born between the 32nd week of pregnancy, again, there's just a greater chance of being, you know, born with cerebral palsy or will develop. Intensive care for premature infants, though, I mean, we know we're in 2024. It has improved a lot over the past several decades. Babies that are born very early are, you know, they're more likely to live now, but they may have some medical problems that can put them at risk for cerebral palsy. But again, these are just risk factors. Every situation is unique. It's not a guarantee, okay? Every situation is unique. All right, if we can move on to slide 40. Okay, so now what we're going to talk about are the general causes of acquired cerebral palsy. So the cause of specific cases of cerebral palsy may occur after birth. Okay, just like with epilepsy, even an adult can acquire cerebral palsy through an accident resulting in brain damage. This is generally referred to as TBI, which is traumatic brain injury. General causes of acquired cerebral palsy can include trauma to the head, such as a wound or fracture resulting in injury to the brain, infection of the nervous system, such as high fevers and meningitis, which can be caused by several species of bacteria. Okay, it can be caused by viruses, fungi, parasites. If an infection occurs, it can cause swelling in the membrane around the brain and the spinal cord. That can lead to severe brain damage, and it can harm the motor control centers of the brain. Okay, that can cause CP. Vascular problems of the brain, such as hemorrhage, and then anoxia. This is due to strangulation, carbon monoxide poisoning, smoke inhalation, near drowning, etc. Now, for those of you in this workshop today, if you've taken pediatric CPR, if you've taken it, you may remember when we talk about the chain of survival for pediatrics, the first thing that it starts out with is prevention. Okay. And the reason that is because it's up to us adults to do what we can to try to prevent these types of things like injuries or, as mentioned, drowning. Adults watching kids near water, they should avoid distracting activities like using a computer or a handheld device. Avoid reading, talking on the phone while, children are near water, because if they're under the water for too long, their brain is losing oxygen, which can contribute to things like cerebral palsy. Okay. I don't know, like my family sometimes, I'll put me out there. They sometimes say I'm a little overprotective when it comes to my kids. I don't know if I feel that I'm overprotective, but I've seen some things, working in this field, I've seen some things. I work with multiple individuals who were not born, with the diagnosis of cerebral palsy. I'm going to share this. One of the little boys that I used to work with, he was sitting on a bar stool, like at the kitchen, table there, and it was a bar stool. Well, at 4 years old, he fell backwards. And now he utilizes a wheelchair. He's lost his ability to speak, and he's having to kind of go through rehabilitation to try to relearn the skills that he had. So I don't know. I don't feel I'm overprotective. I just feel if I see my kid on a bar stool, I'm like, if I see it could happen, I just do what I can to try to prevent. That's where that whole prevention thing, comes into play. Because like I said, I've seen things, and just being mindful, doing what we can to try to just be aware that this stuff, does happen. So anyway, I'll get off of that right now too. All right, let's go ahead and look over on slide 41. It should be, yeah. Okay. All right. And early indicators in babies. So early indicators, what to look out for: poor muscle tone in the baby's limbs, resulting in heavy or flopping arms and legs, stiffness in a baby's joints or muscles, or uncontrolled movement in a baby's arms or legs, difficulty coordinating body movements, including grasping and clapping, a delay in meeting milestones, such as sitting, rolling, crawling, walking. I'll say the earlier the diagnosis, the sooner that the baby can get the support that they need. Okay. And I'll actually talk a little bit more on supports at the very end of this session. Okay. All right. Next up on the next slide, if we could, we're going to talk about the unique types of cerebral palsy. Okay. There are several types, but the first one we're going to talk about there is, it's called spastic CP. Spastic CP is the most common type. Spastic CP affects about 80% of the people diagnosed with cerebral palsy. In people with spastic CP, you're often going to find the tight muscles. Now, people who have spastic CP, they have increased muscle tone. This means that their muscles are stiff, and as a result, their movements can be limited. Now, depending on the type of spastic CP the person has, is going to determine, different skills and things of that nature. The most severe is called spastic quadriplegia. It affects all four of the limbs, the arms, the legs, and, the head and the face. They usually cannot walk and often have other developmental disabilities, such as intellectual disability. They may also have seizures, problems with vision, hearing, speech, things of that nature. The next type of CP we'll talk about is athetoid or dyskinetic. This is unintentional or uncontrolled movements and will often be due to an ever-changing level of muscle tone. Now, people who have dyskinetic CP, they have, issues controlling the movement of their hands, arms, feet, and legs, making it difficult to sit and walk. The movements are uncontrollable and can be very slow or very rapid. Sometimes the face and the tongue are affected, and the person may have a hard time, sucking, swallowing, and talking. Okay. Let's see. The next type is ataxic. This is characterized by lack of coordination and balance due to damage to the cerebellum. And then mixed. Mixed occurs when two or more types of CP are present in the same person. So mixed CP, the person may have, spastic CP on one side of the body where they've got the very tight muscles, and then on the other side they could have the dyskinetic, where they've got, they're unable to control that movement. Okay. All right, let's look over on the next slide. A common question that people have about cerebral palsy is, does cerebral palsy affect intelligence? And well, the answer is not directly. Okay. Generally, cerebral palsy is a motor disability, meaning that it only directly affects motor skills such as movement, muscle tone, and posture. However, up to 50% of individuals who have CP, they also experience some intellectual impairments. Now, when it comes to intellectual disabilities, they can be a link of cerebral palsy, which means the two conditions, they often occur together. However, cerebral palsy and intellectual disability, they're not directly related because they are caused by damage to two separate areas of the brain. A common myth about people who have CP is that, well, if they use a wheelchair or they have speech limitations, a common myth is that, well, they must not understand what we're saying. That person doesn't have a way to communicate because their speech is, delayed. Well, that's false. Often an individual's motor impairments can, yes, cause them to struggle with communication despite having a completely normal intellectual capacity. I have a friend of mine who has cerebral palsy. He is a lawyer, very, very smart. I don't know if any of you here in this workshop today, if you've ever seen the comedian Josh Blue, if you've ever had the opportunity to watch him, I highly recommend him. I had the opportunity to see him live at the Improv, and oh, I'll tell you, he's one of the funniest comedians that I've ever sat through. Okay, he's very, 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 very funny. So anyway, I guess I highly recommend him. You can find him on YouTube and things like that. But he's a funny guy. But he's diagnosed with cerebral palsy. But it doesn't matter. He just still does his thing. You know what I mean? Another thing I want to talk about, oh yeah, if you have the opportunity to check out a video by a young man named Tyler Green, okay? Green is Greene. I think that's how he spells his name. He tells us about what it's like for him being a sophomore in high school while also dealing with some of the struggles of having cerebral palsy. I'll tell you right now, he had a GPA of 3.5. Even after high school, he did go on to be an incredible advocate for folks who have different, unique abilities. He was one heck of a guy. The video is called "Don't Be Surprised, I'm Tyler," and it can actually be found on the I'm Tyler website. So if you get an opportunity to check out that video, it's really cool. Just talks about, his experience in high school. It's really good. So anyway, all right. Moving on, we're going to go ahead, and I think this is a good time to just go on to some general information on intellectual disability. So we'll go ahead and do that. All right, it says intellectual disability, or ID, is a newer term for mental retardation, okay, which was MR, or they were calling it cognitive disability. So when you hear intellectual disability, just know that that is the new term for mental retardation. Of course, we don't use that verbiage anymore. And then cognitive disability. Intellectual disability, it's just a term used when a person has certain limitations in cognitive functioning and skills. Okay, that could be communication skills, social, self-care skills. I believe the term changed from MR to intellectual disability, I believe it was 2010, if I remember correctly. All right, let's go ahead and look over on the next slide, please. All right, depending on the severity of the brain damage, intellectual disability can be mild. Okay, that's when the person has an IQ level of 52 between 69. Now, a person with mild intellectual disability, they have some difficulty learning to read, write, some other academics, but they can learn, they say up to a 6th grade level or by late adolescence. But I always say don't stop, just because they put that in the research, a 6th grade level. The thing is, though, don't stop. If you are educating, children and they are diagnosed with an intellectual disability, just keep teaching. typically when it comes to mild, it's not usually diagnosed until like preschool or first grade when the teacher starts to notice delays. Okay, that's usually when the diagnosis comes through and they have a meeting and, you know, kind of see where to go from there. Let's see, moderate. This is when the IQ is between 36 and 51. Now, a person diagnosed as having moderate ID, they may have poor social awareness, but you know, they typically can talk or learn to communicate, even if it's not with speech, you know, using pictures and communication devices, things of that nature. Severe, this is when their IQ is 20 to 35. Now, the person is able to learn some self-help skills, usually will have limited speech, may be able to say a few words. But again, just depends on the individual. Profound, this is when the IQ is 19 or below. They just have limited understanding of speech or gestures. More than likely going to communicate non-verbally. They just have extreme cognitive limitation. Typically, you know, people who have intellectual disabilities, just like all different types of people, they enjoy the company of well-known family and caregivers, but sensory and physical impairments often do limit like social activity. So this child may not like to go to family functions and things like that just because it may be too loud. They just may have that sensitivity to things like that as well. Okay. Next up on the next slide, let's go ahead. We're going to talk about some of the characteristics, and they can include the person may have difficulty communicating, delayed responses, poor memory, emotional outbursts, difficulty with logical thinking and problem solving, developmental delays like with language and walking, avoiding social interaction, poor concentration, inability to recognize familiar voices or faces, and difficulty processing auditory or visual stimuli. Now, while these signs, they're not absolute indicators of intellectual disability, they can serve as a, you know, a sign to maybe speak with your child's doctor for an official diagnosis. Early intervention may help to prevent the development of problematic behaviors like self-harm and aggression, and can also, when it comes to early intervention, it can offer different therapies for the person to assist them with independence and life skills and things like that. I'm actually going to talk more on that, the early intervention, toward the very end. Okay. All right. If we could look on the next slide. All right, causes. Intellectual disability can be caused by any complication that starts anytime before the child turns 18, even before birth. It can be caused by injury, disease, or even problems just in the brain. Several hundred causes have been discovered, but in about 1/3 of the people affected, the cause remains unknown. Next slide, please. So we're going to talk about the major known causes of intellectual disability. So the first one is the fetal alcohol spectrum disorder. This is a condition in the child that results from alcohol exposure during the mother's pregnancy. Fetal alcohol syndrome causes brain damage and growth problems. Next slide, please. So the next one we're going to talk about is Fragile X syndrome. Now, this is caused by a defect in the FMR1 gene, and that's located on the X chromosome. Now, the defect or the mutation on the FMR1 gene, it prevents the gene from properly making a protein called it's called the Fragile X mental retardation 1 protein. This protein, it plays a role in the functioning of the nervous system. The exact function of the protein, it's not fully understood yet, but we know that a lack of or a shortage of that protein, it can cause symptoms that can result in Fragile X syndrome, which can result in intellectual disability. And then the last one I'm going to talk about is Down syndrome. Okay. Down syndrome results when abnormal cell division involving chromosome 21 occurs. The cell division abnormalities result in an extra, partial, or full chromosome 21. So when we think about human cells, they normally contain 46 chromosomes. We get 23 from mom and 23 from dad. Trisomy 21 is the most common cause of Down syndrome. About 95% of the time, Down syndrome is caused by trisomy 21. What that means is, well, the person has 3 copies of chromosome 21 instead of the usual the 2. We have 2. Person who has Down syndrome, they have 3. Just an extra chromosome. This could just be caused by abnormal cell division during the development from the sperm and the egg cell. Now, same as with any person in general, okay? Every person that you meet who has Down syndrome, they are an individual, okay? Intellectual and developmental delays, they may be mild, moderate, severe. Some people are healthy while others have significant health problems such as, heart defects. But just like I said, anyone else, okay? All people who have Down syndrome, they are all unique. Okay, they all have their own personality. So it's just important, like I said, to get some basic information on Down syndrome itself. That's great. But you still have to go and get to know the individual as a person. And it's just like even people that don't have written diagnosis, even when it comes to like genders, women are going to share some of the same characteristics as other women. Men are going to, share the same characteristics as other men. But the thing is, just because we share those same characteristics based off of, let's say, gender, we're still unique. We're still our own person. And it's the same thing. We just don't want to like clump people together and say they're all the same based off of their diagnosis. That's it. All right, let's go ahead and look over on the next slide. We're just going to talk a little bit more on causes of intellectual disability, because other causes happen while the baby is being born or even soon after birth. Still, other causes of intellectual disability sometimes can happen when a child is older. Okay, so let's talk about that. Childhood diseases. All right, just like we talked about when we were discussing epilepsy, things like whooping cough, chicken pox, measles, they can cause meningitis, and the bacteria or any virus can cause meningitis. Viral meningitis is more common, but bacterial meningitis is more serious. It can lead to brain damage or even a stroke. Now, in some cases, we know it can be fatal. So when it comes to childhood diseases, that could be a cause as well. Also, accidents such as a blow to the head or near drowning can cause brain damage. Substances such as lead, mercury can also cause irreparable damage to the brain and the nervous system. Next slide, we're going to talk about poverty and cultural deprivation. So children in poor families may become intellectually disabled because of malnutrition, disease-producing conditions, disadvantaged areas, which may cause them to be deprived of many common cultural and day-to-day experiences provided to other youngsters. Research suggests that under certain stimulation can result in irreversible damage and can serve the child. It could cause intellectual disability. Next slide, please. All right, we're going to change it up just a little bit. We just went over just a brief introduction on those 4 developmental disabilities, right? We went over epilepsy, we went over autism, cerebral palsy, and intellectual disability, okay? So now what we're going to discuss is transporting a passenger who may have a visual impairment. Next slide, please. So having a visual impairment, it can range from being totally blind to requiring the need for glasses, or the person may be legally blind. So totally blind refers to a complete loss of sight, which describes the complete loss of all visual light perception. Most people who are diagnosed with blindness, they have what's called legal blindness. This is different from total blindness. Most people who are legally blind, they can still see some light, but the objects in their vision may be very blurry. Now, most people who are blind, they have at least some usable vision, and, it can help them to move around in their environment, just do things in their daily lives. But if you think about normal vision, okay, being 20/20, that means that you can clearly see an object 20 feet away. But if you're legally blind, your vision is now 20 to 200 or less. That means if an object is 200 feet away, you have to stand 20 feet from it to be able to see it clearly. But a person who has normal vision, they can stand 200 feet away and they'll be able to see that object just fine. Okay. Now, when it comes to visual impairments, I mean, there's a lot of information about assisting a person who has a visual impairment. I just want to share some tips that you can use when transporting a person who has a visual limitation. This is going to be from my experience working with people who have, different types of vision loss. So the first thing I always say is just inquire, inquire about the type of vision or the lack of vision that person has. Some folks who have blindness, they may not be able to see past their nose. They may not have peripheral vision. They may have blurred vision. Their side of vision could be in the tunnel format. Bottom line, get to know what kind of visual impairment the person has so we can better assist them. Now, I have included some pictures on the slide there that kind of help us to see how they may view the world. So if we can go ahead and look on the next slide, please. Yeah, there it is. So got the two main ones here, farsighted and nearsighted. So a person who is nearsighted, okay, they see objects clearly that are near, while objects in the distance are going to be blurred. That's nearsightedness. Farsightedness means that you can clearly see objects far away, but have difficulty seeing objects that are closer. Okay. All right. We could go to the next slide. Peripheral vision. Yeah, that's the next one. Okay, peripheral vision. This is side vision. This is what's seen on either side by the eye when looking straight ahead. Now, a person that lacks peripheral vision, they're not going to be able to see what's going on either side of their head. Let's see. We've also got blurry vision. This is just the loss of sharpness or eyesight or of eyesight, making objects appear out of focus or hazy. Next slide, please. I think it's the last one, should be tunnel vision. Yeah, okay. So tunnel vision, this makes it difficult to see what is on the outer edges of your vision. This means that you'll be able to see things straight ahead, but the sides of your vision will look blurry. This includes visions on all sides, not just left or right, but it's also going to be above or below the direct line of sight as well. That's tunnel vision. Next slide, please. So now let's just talk tips on things that we can do when transporting a passenger who has, visual limitations. So the first tip that I've included here is just to greet the individual appropriately. Always treat a person who is blind, I put quote normally, okay? I mean, how you would talk with anybody. Speak first, introduce yourself, shake hands. It's totally appropriate to shake hands. But only if a hand is offered, you know what I mean? It's also polite to look at him or her during the conversation. I always say to adopt the same level of position, like sitting or standing, if they have that limitation. Do not be afraid of using normal language. You can use words like see or look, or even common expressions like see you later. Keep in mind that people who have visual impairment, they have the exact same vocabulary as sighted people. Always ask first before offering any help, and just don't be offended if it's refused. Some people have had bad experiences of what a sighted person thinks is being helpful. Some people I know that have visual impairments, they often wish that everyone would just treat them as people and not as a person with a condition. Unsolicited and extra assistance is something that may make them feel very small or just, incapable. So if you offer assistance, wait until the offer is accepted. Then listen or, ask for instruction on how you can assist them. Don't assume that they need your help, okay? We see this a lot, so don't assume. The next tip we'll go over is to be precise if giving instruction. This is so important when working or transporting a person who has a visual impairment. When we're giving directions like pointing and saying, it's over there, that's not much help, okay? You may use statements like, it's to your left, or even you can ask them to take your hand so you can point in the direction to show them where the object is. So an example on a transport vehicle could be, the seatbelt location, you know. So instead of saying it's right there, you could say something, it's on your left, or I don't know, I'm trying to think of another example on if they don't understand left and right. You can use other examples like having them feel where it's at. Okay. Another thing that we've learned when we're supporting people who have limited vision is they use their hands a lot to touch, because their hands can be kind of like their eyes. And what I mean by that is if a person is blind, they rely on their sense of touch for pattern perception. Okay, so like, us, we depend on our vision. Okay, so you may transport a person who is blind that asks to touch your face. And the reason that they want to touch your face is to kind of get an idea of what you look like. Okay, so if it's a beard or if it's long ponytail or wears glasses. Now, of course, if you're not comfortable with somebody, touching your face, you can just, verbally tell them some of your physical characteristics. So they just have an idea of what you look like. Okay. All right, let's go ahead and go to the next slide, please. All right, more tips. Give adequate space around obstacles and hazards and plenty of time to respond. You may need to let the individual know, to bend their head down low to avoid the roof of the van or the car. You may tell the person if the door opens, toward them or away from them. So just kind of explain things as well. Describe any sudden changes. When you're walking with an individual who is blind, if you're approaching a curb, let them know it. If it's a step up, a step down, if the surface is going to change, now you're going up a ramp, or now instead of walking on the concrete, it now changes to gravel. So you can give them kind of a heads up that the surface is going to change. Okay. Be mindful too that walking downhill can be more difficult than walking uphill. Explain noises and silences around them. Even me personally, anytime I enter a room, even like the bathrooms that we have here, we have a young lady who is blind, and anytime I enter the bathroom, I just make it very known that I'm there. I'll say hello, I'll make noises so she knows that I'm still in the restroom, because I put myself in that position. It would be very uncomfortable if somebody just walked in the restroom behind me and I had no idea, so communicate with them, talk with them, And then the next one on the list is always stay on the least dangerous side of them unless they have a preference. What that means is if you are walking close to the edge of the street, try to place yourself on the street or the curbside. That way, if they fall, they're not falling directly into traffic, or they don't, kind of walk off the curb. So put yourself on the street side. And honestly, I do this with my kids too. If we're walking up Walmart, I always put myself on the traffic side, walking up to the store, and I put them on the side where all the cars are parked, because my point of view is if somebody starts to swerve into us, I'm pushing my kids to safety. I'll get hit by the car, or I don't want them their kids walking into traffic, so in case someone's not paying attention. So I don't know, it's just a safer way. The next one is allow the person plenty of time to hold the handrail securely, and judge if the first step, how high it is. You can help them with that. Never propel or steer a blind or visually impaired person backward into the seat. You just never want to presume where the person wants to go. It's not uncommon to see a person being propelled or steered, and that could be viewed as very uncomfortable or even demeaning to the individual. So we don't want to steer them with our hands where they need to sit. Ask for details of where they would like to be guided if they need that. You know, some people who have a visual impairment, they may choose to hold onto your arm or your shoulder, or they may be independent, utilizing their cane. So again, it's just always good to ask, would you like some help, before we go and assume that they need that help. All right. Now, another thing I kind of want to talk about just real quick, you know, is in some cases, a person is accompanied by a guide dog. We see it all the time. You know, they have a guide dog, but just know that the animal must never be distracted. Okay. Often it is the animal that receives the most attention more than the owner. The owner's ignored and the dog is getting all the attention. The thing is, though, together, they usually make a good working team, and the individual who's being guided, they usually don't need any extra help. Of course, ask if they would, but main thing is we don't want to distract the dog because he's technically working. Okay. All right. Let's go ahead and look over on the next slide. We only have a couple more little things that we're going to talk about, and then we'll end this workshop. Okay. So we're going to talk about speech impairments. If we can look over on the next slide, please. Okay. So speech or language impairment is a communication disorder such as stuttering, impaired articulation, a language impairment, receptive language issues, or a voice impairment. Next slide. So what causes someone to have a speech impediment? There are many possible causes of speech disorders. For example, brain injury, autism, hearing loss. Problems or changes in the structure or shape of the muscles and bones used to make speech sounds can also cause speech difficulty. These changes may include cleft palate and tooth problems. Damage to parts of the brain or the nerves, such as from cerebral palsy, that control how the muscles work together to create speech can also play a factor as well. Next slide, please. We're going to just go over some tips for transporting a person who has a speech limitation. It is necessary to ask short questions that can be answered with a few words. It could even be answered with a nod or a shake of the head. Check that you have their attention before talking. Reduce background noise and distractions. Speak clearly and slowly, and use appropriate tone of voice. So you may need to break the instruction into small parts. Check the person's understanding periodically and pay attention to their facial expressions. You know, if you're talking to somebody and they're giving you a look of confusion, you may have to reword it. Okay. If you're having trouble communicating, also you can, let's if we go to the next slide. I want to make sure I'm going in the right order here. I use that for the guide. If you are having trouble communicating, ask if the individual can write the message or use maybe a phone, tablet, communication device. Now, most people, you know, they carry their phone with them. They may be able to use the notepad on their phone to send that message across. Check to make sure hearing aids and glasses are being worn if they have them, and then face the individual and maintain eye contact. Give the conversation your full attention. Next slide. So I kind of mentioned this a little bit, but we're just going to elaborate just a little bit more on this one. If you are not sure what the passenger said, it's okay to ask them to repeat their statement. If the individual is accompanied by another individual, you don't want to address questions, comments, or concerns to the companion. Okay, so if they have an interpreter with them, speak to the person, not the interpreter. Okay, you don't want to pretend that you understand what's being said. Instead, repeat what you have understood and allow the person to respond. It is okay, again, to let them know that, you know, I'm sorry, I didn't understand what you said. Can you please say it again? You just don't want to agree to pacify them. Okay. Especially if you really didn't understand what they just said. If you just smile and nod or say, yeah, that sounds good. Again, you don't know what you just agreed to. So be very careful with that. Let's see. Next slide, please. Oh, another tip is you don't want to play with the individual's communication device. You know, if you think about it, the communication device is kind of like an extension of the individual's personal space. And we just want to make sure that we're not pushing buttons or touching it without asking permission first, because that's their voice. We need to make sure that it's taken care of. Maintain ordinary eye contact, especially if they're having a hard time speaking. I want to talk about having a conversation with someone who stutters, okay? It's so important not to make remarks like, slow down, take a breath, or relax. Such simplistic advice, it can be very felt as demeaning and not helpful. So let the person know by your manner that you're listening to what they're saying. So instead of telling them, yeah, I'm listening, just show them that you're listening by, making eye contact with them and actually engaging in that conversation. Another thing you want to avoid, and I see this sometimes, is when you're in a conversation with somebody and they kind of check their watch. If you've ever been in that conversation where they keep checking their watch, or another nonverbal cue of I'm not listening is if they pick up their phone while you're talking with them. So they're down here. The thing is, as soon as we start checking our watch or picking up our phone, that is a nonverbal way of telling the communicator, hurry up, I'm checking my watch. It might not be what we mean. We might not mean for it to look like that, but if the person is communicating to you, just imagine how they feel talking with someone who keeps checking their watch or picking up their phone, okay? It's gonna just kind of look like we're trying to rush them along, okay? A person who stutters, they know exactly what they want to say, but they may have trouble producing the normal flow of speech. These speech disruptions may be accompanied by even struggling behaviors such as rapid eye blinks or tremors of the lips. So again, the best thing that we can do, instead of telling the person, slow down, it's okay, I'm listening. Don't do that. Just actually listen. That's going to show that person that I have time to listen and have that conversation. I have also noticed too, people who tend to stutter, if they're excited or angry, they tend to stutter more. And also if they feel rushed. If they feel rushed, they're going to stutter more. So just be present, All right, if we could look over on the next slide, got a couple more tips here. The next one is be patient. Yes, give the passenger more time to finish what they're trying to say, okay? Wait for them to finish rather than correcting or speaking for the person, okay? Let them finish. Speak to the person the same way you would speak to anyone who doesn't stutter. And the best advice I can give is just show empathy. Be professional. Allow the passengers with a speech disorder to maintain their dignity. Okay. All right. Next slide. The last topic is going to be just an overview and best practices for transporting a person who is diagnosed with a hearing loss. Now, hearing loss, it may be mild, moderate, severe, or profound. It can affect one ear or both ears, and it leads to difficulty in hearing conversational speech or loud sounds. Hard of hearing refers to people with hearing loss ranging from mild to severe. People who are hard of hearing usually communicate through spoken language and can benefit from hearing aids, cochlear implants, and other assisted devices, as well as captioning. Cochlear implant, real quick, what that is, it's an electronic device that it partially restores hearing. It can be an option for people who have had severe hearing loss from inner ear damage, who are no longer helped by just like hearing aids. Now, unlike a hearing aid, which amplifies the sound, a cochlear implant kind of bypasses the damaged portion of the ear to deliver sounds and signals to the hearing nerve. I mean, which is just absolutely incredible. I mean, technology, right? Next slide, please. People who are deaf mostly have profound hearing loss, which implies very little to no hearing. They usually use sign language for communication. So It's always a good idea to, learn a little bit about how this person communicates. Next slide, please. Just going to wrap up with some tips. All right. If you are communicating with someone who has a hearing loss, always face the person who has that hearing impairment. Make eye contact. Keep it while you're talking. Don't look away. Don't cover your mouth while you're talking, just because if this person relies on lip reading, they're not going to be able to understand. Check noise and lighting. Turn off or move away from background noise. Make sure your face is not like in a shadow to where they're not able to see your mouth moving, or if the sun is in their eyes, switch places. Keep your distance. They say to stand about a meter or two away from the person who is deaf. This is important for people who use hearing aids, if they're lip readers, or if they're using sign language. Speak clearly, slowly, and steadily. And as I say that, I realize I'm talking faster now because it's already noon and I know we're done. So I am speaking a little bit faster. I'm hoping you guys are keeping up with me. Just don't mumble, don't yell. And another thing too, if you're speaking with someone who has hearing loss, don't exaggerate your lip movements. Like if I'll come in close for this one. How are you? Okay, don't do that, because they've learned how to read lips based off of just normal lip movements. The last one, no, it's not even the last one. Take turns. If there is more than one person in a conversation, take turns to talk. What I do if there's multiple people that I'm speaking with, when this person over here is talking, I tend to look at them. So the person who has hearing loss, they know to look in that direction because that's where I'm looking to listen to this person. The next one, repeat and rephrase if necessary. Try to say the same thing, but in a different way if they're having a tough time understanding what you just said. So if they don't understand, again, I'm bringing this back, but if they don't understand the seatbelt is on the left, you may say something to someone who has a hearing loss. Your seatbelt is on the same side as the steering wheel, just to help them to understand where it is if they don't understand that direction, left or right. If you're going to be transporting someone who uses sign language to communicate, open yourself up. There's different apps on the phone. There's the hands-on ASL, the ASL coach. What's another good one? We Sign Basic. Those are just some of those that you can download on your phone. GCC also has a great program with ASL if you want to take it a step further. Okay. All right, next one, write it down. Don't be afraid to write or draw, to help with understanding, and then just keep trying. Arguably, the one of the most important points to remember is to keep trying. Even if the person who is deaf does not understand what you're saying the first few times, don't stop. Some of our partners, they've told us that when someone doesn't hear what they said, and then the person says, oh no, it's okay, it's not important, or don't worry, or they'll say it doesn't really matter if they didn't hear it a couple times. Even if it takes 4 or 5 times of rephrasing or writing it down, just don't give up. Don't just be like, oh, it's okay, don't worry about it, it's fine. Because that person over here that just really didn't hear you feels left out. You know what I mean? So, just keep trying, find different ways to communicate with that specific person. Okay. All right. So I do still want to talk about this. I mentioned it earlier about that whole early intervention thing, because I don't know, if you in this workshop here, if you have a loved one that maybe has delays, I want to kind of give you a little information about, some assistance that's out there. Now, DDD, which is the Division of Developmental Disabilities, they have many services available to families that have children who have developmental disabilities. Now, you can check them out on the Arizona Department of Economic Security website. But when it comes to programs for children, there are two main programs that are designed to support children who have a developmental disability. The first one is their early intervention program. This is for children from birth to age 3. It's going to offer things such as occupational therapy, speech therapy, physical therapy, things that will benefit this child in so many ways. Now, if you're not sure if the person in your life may be showing delays, there is a questionnaire on the website, and it shows if the child is at least 50% delayed, then you can arrange an assessment. Okay. Now, let's say the child is 3, has a diagnosis of autism. What they're going to do is they're going to move them in what they call preschool, which is going to continue on with those services. Preschool's from 3 to 6. Now, age 6, they'll reassess, see what the next step is for that child. But as early as infancy, there is a lot of support that Arizona, the DDD does offer. So just throwing that out there. Okay. All right. What a 2-hour span here. So this training that I did, this workshop that I did here for you guys today, it was designed to discuss some general information on individuals who have special needs. Like I said this morning, I understand there's no one size fits all when it comes to individuals who have unique abilities, but I hope that the information that I provided today will help to understand a little bit more about some of the individuals that you transport. I do want to thank you guys for allowing me to be here and speak at the workshop. The second session of this workshop is going to be held, I want to say the 13th, September 13th. Is that correct, Lauren?
Correct. And I'll go ahead and put the registration link in the chat box really quick.
Perfect. So in that session, we're going to be talking more on communication tips for drivers, other things that we talk about. Oh, we're going to go over transporting someone with dementia. We also talk about reducing car pollution. What else? Safety procedures with the wheelchair. Yeah, just a lot of cool things. So I hope to see some of you guys on September 13th at 10 a.m. All right, and I guess we kind of open it up for questions. Does anybody have any questions?
There are no questions in the chat box, but if you do have one, go ahead and unmute and you can ask. All right, well, since we don't have any questions, I will go ahead and end the meeting. Like I said, the recording will be up on the MAG website next week, and part 2 of this training will be on September 13th, as Heather mentioned. And I put the registration link in the chat box.